excited tonight to talk to my colleagues about reclaiming your time, talent, and sanity with direct primary care. So I am going to make the assumption that if you're not already practicing DPC, you are certainly interested, and I'm happy to answer questions that you may have. So I wanted to introduce myself and kind of give my backstory on how I ended up as a owner and operator of a DPC practice. So I am a native Texan. I trained in Texas and moved to the Nashville area 4 years ago now, 5 years ago now. It was in 2020. We relocated because my career previously was in graduate medical education, and I was recruited by a major healthcare center here to establish a residency program. And so that is the reason my family and I relocated from from Texas to Tennessee. Previously working in GME, but also heavy on the administrative side in the hospital setting. I really enjoy accountable care organizations and value-based payment, actually. And so I served in that capacity and still do. But transitioned here and worked in graduate medical education. I knew I wanted to pivot from GME because I really felt like medicine could be practiced differently. I still very much had a strong commitment to advocating for the most vulnerable. And so I sought a role with the state of Tennessee's Medicaid program, TennCare, as an associate medical director. It's a unique opportunity to help build initiatives and wraparound services coming from Texas, where our Medicaid population is fee for service, into a managed care setting such as Tennessee was a unique experience for me. And I wanted to be part of that policy. And so I do still serve in that role. But it is purely administrative. And I was not yet ready to give up my clinical practice. And so I made that very clear when I was being recruited by the state and looking at different ways that I can continue to see patients. And that is how I came into direct primary care. It was the perfect option for me because it gave me the autonomy to control my schedule, number one. It gave me an opportunity to not really have to worry about any sort of conflict of interest that may arise at the state. Now, I was a little nervous, right? I had never been an entrepreneur. I had been a not-for-profit and a for-profit healthcare leader, but never an entrepreneur. So this was really going to be my first experience into that. And I took that leap, and I honestly could not be happier. And that's really the take-home message that I want to share with you, is that the autonomy gained from direct primary care has really reconnected my love for working with my patients one-to-one, walking their journeys with them, and really my love for being a family medicine physician. And so my physical practice is located in Murfreesboro. I practice telehealth throughout the state of Tennessee. But because I am from Texas and was still licensed in Texas, I started seeing patients virtually there. I was unsure how that would work and how that would be received by folks who would not see me in person on a routine basis. And it turns out that they loved it. And we'll get into this a little bit later, but the majority of my patients are healthy. The majority of my patients are actually entrepreneurs themselves, and small business owners that have small teams that may or may not have another healthcare solution. So I really leaned into that as my target population. But what I found by still practicing in Texas is that folks really loved having a relationship with a physician, being able to call a physician and say, hey, is this something that I need to go to urgent care about, or something that you can help me with? And they were still able to get the care that they felt like they needed. And so because it was working so well in Texas, and I had a request and demand for some patients in Georgia, I expanded my practice to Georgia as well. So that is how Rapha, which is a Hebrew word for healing, by the way, how Rapha is a multi-state direct primary care practice. So really a Tele2 work days and what this looks like. I don't really have to explain much to this audience about what it is, but it's really volume over value. When we think about what we do as primary care physicians, tons of visits back to back. I was very well attuned into that role, being paid for the number of patients, not only that I saw, but even that my residents saw. So it was really a matter of cranking folks through. No control over the electronic health record that was used. And so, if you've met one EHR, you've met one EHR. I was trained back in the day of paper and writing prescriptions. And so I had the uplearning of how to utilize electronic health records. And as we all know, it did not make our lives easier as they had previously promised us. So lots of work, lots of time in the evenings managing inbox and patient request, and then the billing codes and the prior auths and the bundles, and trying to meet all of the nodes, especially when you're taking care of Medicare patients, and making sure that you are coding for all of the right things. How much time in our days do we spend doing that? I compare this to what life is now like in direct primary care practice. No patient ever books a 15-minute appointment with me. That's not an option. The minimum appointment is at least 30 minutes. I do not see people back to back. No longer do I have like someone in the next room waiting for me. And very rarely is there anyone ever sitting in my waiting room. That's the way that I appreciate practicing. I like being able to, when the patient arrives, being ready to receive them. That's important to me. And I like being able to take the time to talk to my patients. This is why I was drawn to family medicine when I was in medical school. I had the privilege of working with extremely talented family docs who really did it all in their communities. I mean, we started the day at the hospital, transitioned to the clinic, did a couple of procedures, went to the nursing home at lunch, and then back to the clinic. I loved the idea of being able to really fully serve my patients. And this is why I went into family care. It's why family medicine, it's why I went into graduate medical education, is to teach others. And so I really wanted the relationships back. I was okay with not practicing inpatient medicine again or OB again, but I did want the relationships with my patients back. And DPC has truly given me that. I'm no longer spending my evenings charting. Charting becomes much simpler when you're not trying to satisfy the needs of some of the quality metrics that our payers require of us. Minimal prior auths. Now, there are some of my members who still have commercial insurance. They may require a prior authorization for a medication or an imaging to be done, and I'm still responsible for that. But it is a much, much less volume. I can count on one hand the number of prior auths I do in a month. So that's been a big transition for me as well. So this is what I believe our current gap in primary care looks like. We spend more time documenting in our EHRs than we actually do with our patients. There is an issue of burnout, and I think that this is really underreported. I know I didn't want to report it. Maybe it was the time that I came up in training, but I did not want to report about how all of the other demands of practicing medicine were influencing my personal health, my relationships with my patients, and my relationships with my colleagues. And it took a while to realize that that's what it was. And then there's that admin work that's still so much of your personal time every day. So many of us, we may get to clinic early. There's some pre-charting that we need to do during lunchtime. Rarely are folks, just eating and not while also trying to do double duty and eat while they do some work, taking a walk, just being able to kind of take a break in your clinical day. is not something that many of us can say that we do. And just up to 9.2 hours per week. I mean, that number to me is astonishing, that's what we're doing when thinking about all of the different EHR clicks to just keep up with everything when it comes to charting for our patients. So why does this gap exist? I think that it's a couple of issues. So for some of us, it is a bit of a knowledge gap in what other possibilities are. I think for family medicine physicians, we are attracted to how broad our specialty is. And I have seen many of us will niche into different parts of our specialty at different times in our careers. That is very common. But it's almost like it's too much, and it creates some uncertainty about what we can really do when we think about practice on our own. A competence issue. So we are highly trained in clinical care, and many of us have administrative and leadership experience. So we are strong competencies there. But when thinking about owning a business and really having full autonomy to practice how you want to may create some fear of failure. I think this is why, in general, we see more employed physicians than physicians who currently own their own practice. And then performance. We hold ourselves to very high standards. We want to always be there for our patients in their time of need. We want to make sure that we're delivering care as it's needed. We want to make sure we're delivering the best possible care to our patients. But that often leads to exhaustion and kind of at the expense of ourselves. So what is direct primary care? So direct primary care is a membership-based model. So you set a fee, a monthly fee that you would like to charge to provide services. That is completely autonomous to what you desire. And many things need to go into that, right? So you need to think about the area in which you practice, your overhead expenses, obviously, and what other components are going to be included in your membership fees. So for my practice, it includes both visits with me. For me, that's unlimited. For another provider, that may not be the case, but it's unlimited visits with me, and it's also labs. So I'm contracted with LabCorp, and it doesn't matter where my patients live, Tennessee, Texas, or Georgia. I can order their labs at LabCorp, and they can go and get those done. Those things are included in the membership fee.
Well, I'm actually on a Zoom call. I got it.
Okay. And so they pay that fee. They're allowed to pay it annually, right? So again, you're in charge of your practice. So do you want to offer a discount, a 10 to 15% discount if members pay their fee? I have a discount for additional family members that join the practice with you. So again, all of this is determined by you as the practice owner. There's no third-party billing, insurance hassles, or CPT codes. So yes, I see patients who have commercial insurance, whether it's their plan or the plan of their spouse or someone else is providing that plan. I explain to them that they can still use their insurance for imaging, for medications, any other needs. If I refer them to a specialist, they can, of course, use their insurance there, but I do not bill insurance. This is a hard decision for me, actually, because I get this question every week, like, will you ever consider taking insurance? But I would really have to hire more individuals to work with me in my practice just to manage the insurance piece of my practice, if that were going to be the case. So for me, the option right now is just absolutely no insurance billing. Yes, members can use their health savings accounts or HSA to pay their direct primary care fees. There is current legislation right now that limits the amount annually you can spend. Typically, a DPC membership falls within that. Okay, now we'll talk in just a little bit about concierge practice, but typically a DPC membership will fall within that cap. But it is, up to the patient to be mindful of what their individual cap is set on their HSA. There's also an alliance or association of DPC physicians who are working with legislators to remove that cap, so that we can increase access to direct primary care for all. So why do patients who have insurance still prefer direct primary care? It's the access. It's the access. In a direct primary care practice, it is very rare that a patient is going to wait more than a week for an appointment. If you all have attempted to make your own appointments or appointments for your family members, you know that you are waiting weeks to be seen for just a basic physical. And if you have an acute concern, you're probably not going to be able to see your primary care physician. You may be able to see their colleague or their mid-level provider that works in their office. My patients love direct access to me. As I said, many of my patients are business owners themselves. They don't have time to wait. They don't want to, wait 2 days for a nurse to call them back. My patients can text me through a HIPAA compliant line. They can email me and they'll get a response. And so my panel is intentionally kept low so that I can provide that type of service. That's my choice. But this is why individuals will pay for direct primary care on top of their commercial insurance benefits. So I hope you understand by now there's tons of practice autonomy in a direct primary care model. Again, it's up to you. So you can limit your visits and say, for this membership fee, you can have 2 visits with me per month, or you can say unlimited visits. Just like any other practice, you're going to have high utilizers, those patients that are going to want to call, have questions about things, want you to review the latest supplement that they saw on TikTok, or patients that are super concerned about any and everything that happens. And you're going to have underutilizers that you're not going to hear from for a few months. Okay, we have that as well. And then you're going to have tons of people who are in the middle and really only reaching out to you when they need it. They still pay everybody still pays the same monthly fee every month. So it's kind of like having a physician on retainer, if you will. But you're going to have that same kind of range that you have in your practices now, where you'll have underutilizers, overutilizers, and a lot of folks in the middle. Again, same day or next day access. I really appreciate this. If a patient messages me that they're concerned, especially if they're ill, it's cold and flu season, they have a concern, try to work them in quickly. If they need a procedure, I still do procedures. So if someone needs sutures, they need a joint injection, manage all that in the schedule as well. I do home visits because that's something I'm willing to do. And so that's also a part of it if a patient needs to be seen, as well as telemedicine options as well. So products and additional services, this is kind of, the opportunity for you to explore other things that you may be interested in adding to your practice. So this could be anything from actually selling or providing medications to your patients. You can operate a pharmacy out of your practice. You can partner with compounding pharmacies to offer some medication as part of an additional service in your practice. Some physicians are authors and write books. I have colleagues who have journals that they have created and sell and share with their patients. All of these things are available to you because there is no insurance oversight to say, that this could not be included as part of that service. You can run promotions and specials at any time. Something that I like to do is during September and October, which are open enrollment for commercial plans and for plans through the Affordable Health Care Act, I'll waive my registration fees or I'll do 50% off your first month. Or if you want to partner with an organization, if you're doing vending, and by vending, I mean like you're setting up at a health fair or you're doing some sort of talk with a particular organization and you want to offer to the Lions Club, for example, if you're doing a talk with them and you want to offer them a special to join for a certain period of time, you can do that. Because you really have autonomy in how you run your practice. So again, the emphasis shifts from volume to value. It is much more about the relationship that I have with my patients, what their true and perceived value is that I provide as their physician. So many people, and I mean, like so many people, like I'm getting calls all day, but I have some patients, my overutilizers are typically people that just have a quick question about, is something okay? Or, hey, should I be concerned about this thing? Is it time for me to update my mammogram? Those type of things. They really appreciate having the relationship with their physician, and they knows them, knows their family, has spent some time getting to know them, that they could reach out to for a quick question. Um, I think we as family docs really started and leaned into the trend of DPC. Now there are many other specialties that are following us. Just in the Middle Tennessee area alone, there are neurologists, dermatologists, and cardiologists who all practice in this model. I've gotten to know them and network with them. But I think that we, as family docs, really led the way in this. AAFP has an annual conference every year dedicated to direct primary care. It is in July. This year, it is in New Orleans. And so I invite you to consider coming if you're interested in learning more and connecting with other physicians. We have several members of our chapter who practice in this model. But it really gives us an opportunity to have these longer connections with our patients and truly be able to focus on more preventive care type of things, being able to really review their health history. I know some physicians really appreciate doing nutrition counseling as part of their practice. This gives them an opportunity to do so. I really enjoy connecting my patients with behavioral health therapists and working on some more therapy type of things during the appointment. And so that's something that people are attracted to my practice about. Like they know, like, yes, I will prescribe medications, but if you're suffering from insomnia, let's talk about some of the underlying stress that you're experiencing, and really have the time to do that. Again, it's up to you and your practice style. But if you're thinking about a patient panel size of about 600, and again, you determine that based on what your financial goals are, I would say versus, 2 to even 3,000 patients that some of us are managing, it really reduces on the number of administrative clicks, just all of the things that kind of bury you down that you have to do to run and sustain a practice. Predictable revenue streams. So yes, you're going to have some churn. You're going to have some patients that leave the practice. You are going to have to market yourself. But again, you control that and you control what that looks like. I have very little churn, very little patients are typically at least with the practice at this point 10 months before anyone has said, I don't think that I fully need these services. Or I had another patient who needed to have surgery. And so they were going to opt in for commercial insurance through the Affordable Care Act and then return to DPC afterward. And he did. And you have the opportunity to keep your overhead costs low. So what does this look like? Yes, you can have a telemedicine only practice. Yes, you could possibly share space. Yes, you could work part-time. It's all about what your goals are and setting up your practice. So why do patients love this? I love, as a patient, the transparent cost with no surprise bills or deductibles. Insurance, even for a provider, is hard to understand. And what applies to my deductible? And am I going to go see my PCP, get some labs done, and then I'm going to get this bill from Quest 6 weeks later saying that my deductible or my copay didn't cover this amount? That's frustrating. And so the idea that like you're never going to get a surprise bill from me. You are going to just pay your monthly fee. And again, you can pay that monthly or annually, and that's it. You don't have to worry about me invoicing you. Now, if I do a procedure, procedures have an additional cost. You know exactly what that is before we even do it. So if you call me, text me and say, I cut myself, this is what it looks like. Do you think I need sutures? And I say, yes, meet me there. I'm going to tell you how much it's going to cost. And what you are going to pay is not going to be what you would have paid in urgent care. And you're not going to get a bill after that visit. Okay. So again, I got to set that price list for my practice, and my patients know exactly what it's going to be upfront. So no surprise bills. There's no deductibles. Again, they love the direct access. They love being able to call, and you set boundaries up there around that as well. This is not the opportunity to trade one set of burnout for another set of burnout by overextending yourself. I saw in a community group on social media for physicians that practice like myself about making sure that we maintain our boundaries and not giving into this narrative that we are always on for our patients. That's not true either. You have direct telephone access to text or call during normal clinic hours, 8 to 5. If a patient texts after that, they're going to get an automated message that says, you've texted us outside of our business hours. We will answer this the next day. If you feel like it's an emergency, please seek emergent care immediately. Now, I may see that message at 6 p.m. and decide, oh, I'm just going to respond. It's just a quick question that Dave had for me. And that's fine. But if I can't, because I'm at my kid's game or I'm in a webinar with TNAFP, I don't have to. I don't have that pressure to do that. So you still set those boundaries. And those are things that I talk about with my patients up early. So I have, I call them discovery calls. They're absolutely free. It's 15 minutes that jump on a Zoom with a potential patient. And that's the opportunity to get to know them. They know when they book that call, because it says it, that there's no medical advice given during that call. I'm not asking them, I'm not taking a history and I'm not suggesting anything. That is the time for me to explain how the practice operates and for me to answer any questions that they have. That's usually the time when people will say, hey, I'm on a statin, a blood pressure medication, insulin, and I'm thinking about having my hernia repaired next year. Is this for me? And that's my opportunity to say, this could be for you, but you also need an insurance plan if you are on medications that cost a significant amount of money and you don't have, if you have the cash to pay for it, that's great. That's one thing. But if you are concerned about the ability to afford your medications and additional care, this may not be the best practice for you. Or folks who say, I really want this, but I also want something just in case. That's great. Let me help you or point you in the direction of a catastrophic plan, right? So you can sign up for a plan through the ACA that maybe has a high deductible, but it's not going to be something that a low monthly payment with a high deductible, but it's not something you're not going to be paying that deductible unless something happens where you end up hospitalized and really need to tap into that plan. So those are the kind of things that I will say to someone based on what their questions are during that discovery call. That's also kind of where I set the expectations around, this is how you schedule. So my practice has a self-scheduling system. Once you sign up, you have access to the patient's schedule and you're able to select your own appointments. Then we have automated reminders, just like any other practice, for that appointment. The patient can go in and reschedule or cancel if they need to. So that's where we talk about those kind of things. You put in your ACH or your credit card information, and your membership fees are automatically paid every month on the date that you signed up. So that's where I explain that during the discovery call. It's not me giving them advice about what to do with their lisinopril. It is just an opportunity to explain the practice. It's 15 minutes of my time. I rather do that early. And then when they join and schedule their first appointment, then we're off to taking their history and finding out more about them, their health behaviors, their family history, all of those things that we normally do. And we moved on, right? And so all of that process is set up for us on the front end. I also have a system that will send out documents to them so that they understand it's a patient agreement form. So they understand how the practice operates, they understand they're not signing up for insurance, but this is their healthcare solution with me as their primary care provider. When they sign that, it electronically comes back and attaches to their chart, and we're good to go. Then they have access to schedule as a patient. It's an opportunity to reduce the reliance on emergent and urgent care, especially for non-urgent issues. So again, if you can come to me and I can diagnose you with strep throat, you've avoided that bill in the urgent care. So if we can do that during the week, and I think for someone to know that they have someone that they can call about those things when they need to, it really drives down the reliance and them kind of putting off getting evaluated later. So again, this is all relationship driven. If you're not a physician who really enjoys that type of practice style, this may not be for you, because I do think that it is truly a partnership with your patients. So what is the difference between this and concierge medicine? Well, I think that the definitions are held pretty loosely. Concierge medicine is tend to be, I think, thought of as kind of being on call all the time, and you pay a higher premium or a higher membership fee for that service. I think that that is the big differences kind of between the two. I will tell you though that to the community, there really is no difference. And so initially, when I started talking about my practice and, kind of marketing myself and introducing myself, people didn't really connect with direct primary care and what that meant, but they readily connect with membership-based care or concierge care. So they understood that. But I think that we, as family physicians, primary care physicians have really leaned into DPC. Now you even hear it called direct patient care, because as I said earlier, now many other specialties are adapting to this. So those are the differences, I think, the key differences between concierge or DPC. But again, I think for the community and the general layperson, there really is no difference. Okay, so I hope that I have piqued your interest even more and you're thinking about what this could possibly look like for you. It is an interesting journey. Again, like I said, I was not an entrepreneur prior to this, but I have leaned into it, and there is some anxiety, uncertainty with what you're stepping into. But I have absolutely loved it, because I think that it has really, really been the key to fostering my relationship with patients and remembering why I love family medicine so much as my chosen specialty. But I think the first step is your personal readiness. And I just think that is, are you ready for a change? Do you want to practice medicine differently? It doesn't mean that you have all the answers. It doesn't mean that you have a business degree. It doesn't, you're going to learn a lot of these things along the way. And there are communities upon communities to help you figure it out. So once you figure out that, yes, I'm ready for a change, whether that looks like you're kind of mid-career like me, early in your career, there's lots of residents now diving straight into these type of practices, or someone who sees this as how they'll kind of transition into retirement. Are you ready? Do your market research, find out about other practices in your area. Not for the purposes of competition, because I think if you've seen one DPC practice, you've seen one DPC practice it, but just to figure out what people are offering, what people are charging in that space. And then even see there's opportunities where there are lots of DPC physicians who are hiring physicians to join them because they're just that busy. So looking to see what's available in your market. And then business planning. So there are many resources to help you with this. There is a Direct Primary Care Alliance. As I said earlier, AAFP has resources on their websites for family physicians who are in direct primary care. So some business planning, legal and compliance, you will find Facebook groups of DPC docs that share resources all of the time, can tell you about lawyers that they've worked with, can tell you about malpractice insurance, and who the brokers are that they've worked with, and lots of different options for you. And then you just really start, what is your marketing plan look like? How are you going to start educating folks about the change that you're making and how you can continue to serve them? Now, if you are transitioning from an employed situation, you may have a non-compete. So making sure that you're familiar with the contract that you signed to see if that is a concern. Or there are some physicians who already own and operate their own practices, but maybe want to transition out of commercial pay for their practice, or they want to do a hybrid. You can also have a hybrid. You can have some patients who see you and utilize commercial insurance, and then another set of patients who see you via the direct primary care way. I think it really improves access to care. There are so many individuals, especially in our state of Tennessee, that really fall in the gap, right? They do not have a job that provides a commercial plan because maybe they don't work enough hours a week, or maybe they own their own business. Tons of people fall within this. I want you to think about people who work at daycares, people who may work at car washes, at grocery stores. They may not have a commercial insurance provided through their employer because of the number of hours they work. But on the converse, they also make too much money to qualify for TennCare, the state's Medicaid program. So there are lots of people who fall in the gap who need a provider, who can afford to pay a provider $150, $200 a month for care, but because they don't have care access other places. So this is really also an opportunity to improve access in your area. So if you are a private physician who owns your own practice, I would encourage you to think about maybe setting up a path by which individuals can join your practice via the DPC way. Okay, so I have a gift for you all tonight. I really appreciate you joining me. And so on the next slide, there's going to be a QR code for you to scan where you will be able to download this step-by-step checklist for transitioning from a traditional practice to DPC, or maybe you are new to the practice of medicine and a resident or student and thinking about your options. I think this guide could be great for that. But this is something that I wanted to share with you all. Please feel free to scan the QR code. Please feel free to share it with others in your communities and networks that might be interested in what a roadmap looks like for them to transition to direct primary care. So I want to open it up for any questions or comments.
So I have one, Mary Beth.
Yeah, I have a question. I've sort of thought about this before, and as I got into it, it seemed like the figuring out of it didn't save me from the paperwork I was trying to avoid. But I had some basic questions like, how do you handle biomedical waste and the other kinds of office overhead if you're doing direct primary care and even like point of care labs?
Great question. So there are things called Health Procurement Solutions, or HPS, that you can sign up for as a clinic owner. And what that HPS does is they contract with all of the other entities. So they contract with biomedical waste, they contract with like McKesson, that does your medical supplies, LabCorp, Quest. They have already gone out and contracted discounted rates for cash pay practices. So once you sign up with them, and that sign up is free, you're going to pay for the actual service. So you sign up, they send you like, what sort of things you may be interested in. You can check some or all of them. And then particularly biomedical waste, because you brought that up, you meet with them and then decide like, what's my pickup frequency going to be? And it may be really slow in the beginning, right? Depending on the volume that you have. And then you decide they have rates available from there. The same thing with the labs. So point of care labs, again, that's up to you. If you either draw labs or you have a medical assistant or a nurse that can draw labs, you do that in the office, and they come and pick it up. So it depends. I have worked with Path Group and LabCorp before. They provide you all of the supplies because they want that contract. So the supplies are free to you. And they provide a box for the courier service to come and pick it up. I've also dropped off samples because I use LabCorp exclusively now, but I've also dropped off samples. If I didn't call the courier that day, I haven't had a negative experience where they didn't show up. But yes, all of that is contracted through HPS, so a healthcare procurement solution. And those are multiple, so you can pick which one of those you want to be a member of, and it's free to join that.
Could I ask another question?
Yeah.
Okay, when we talk about preventative care and cost, especially as people age, mammograms, colonoscopies, DEXA scans, vaccines, how does that cost get incorporated? Specialists, ophthalmologists, how does that get it factored?
Yeah, that is a great question. And I'm sorry I didn't hit on that. I know I talked a lot about the labs, but imaging as well. So you can, it's not really a contract, but once you open your practice, you let an independent radiology practice know that you're there, and they give you their cash-based price. So I'm in Murfreesboro. So I use Premier Radiology, which is associated with Ascension St. Thomas. And so the cash-based price, my patients, I had somebody who had pneumonia. They paid $25 to get their chest x-ray. They didn't have insurance. So they paid $25 to get their chest x-ray. They actually offer free mammograms during October, but typically a mammogram can be $50. I think if they wanted to do the 3D option, it was $125. I had a patient who actually got a brain MRI for $250. So their cash-based prices, you have the list. Again, I am very big on letting my patients know how much it's going to cost up front. So you have the list. Premier will provide that to you. They get your MPI number, they get your fax number, and you're going to just write an order like you would normally do. So I have practice letterhead. I write that order, I fax it to them. Electronically. I always give my patients a copy of the order in case something happens, but I can tell them like, hey, your chest x-ray is going to be $25 and this is why I think you should get it. For the specialist, there is a website called MD Save. It is also primarily in the Middle Tennessee area, physicians who are also practice with St. Thomas, but it's contracted rates to see subspecialists. So again, I had a patient who needed a stress echo. And so we were able to get that done. And so again, you have to have a little bit more ownership in that as their primary care doctor. it's not, I don't think I don't think through MD Save a patient can just refer themselves. I think they actually need you to say, this is why this patient needs to be seen. I shared my notes and EKG and stuff like that before they went in the labs and that sort of thing, just like a normal referral. But again, that patient knew how much it was going to cost before they saw that doctor. So it was like $350. There's different rates depending on who they need to see. Yes, so those are really good questions. And sometimes the specialist part can be challenging because like I had colleagues, right? Because I had already practiced in this area. I had colleagues that I really loved and really loved working with, but because they were a part of a larger healthcare organization, they couldn't see my patient for a cash pay. It was very strange. But their practice didn't allow them to do that. And so, obviously that was a little bit disappointing, but there are other colleagues, certainly in this area, that you can help connect patients to. Thank you for asking that, because I failed to mention that. I appreciate you asking that.
I want to add a quick plug for the Academy as well for TNAFP on that as a follow-up to that question. Now, we don't have resources for labs or medical waste and that level of the practice, but what we are doing is building out, and I put in the chat here, we're building out some resources specifically to help private practice physicians in rural areas and small communities as we work to rebuild that independent physician workforce, and everything from value-based care to insurance, legal services. We got practice consulting. If we can't do it internally, we've got partners who are based in Tennessee who are helping with all the business side things that you might need to run your own practice, which will certainly apply in a DPC setting. So we're finalizing now with banks and an IT, just brought on an IT group. So all the things that you think about in setting up and operating a practice, we want to help members who choose to go that way with the support and a kind of a one-stop shop area. So that's another side of it, in addition to some of the things that you all were talking about.
That's awesome, Dave. That's really exciting news.
I have a question while others are thinking, Dr. Green, just out of curiosity. You talk a lot about the benefits and for the patients and for the physicians who are going this direction. In your experience with your patients, maybe any who have come in and transitioned out, or just general feedback that you've gotten, have you learned anything where people say it's not what they expected, or any constructive feedback that they've given to say this, I wanted it for these reasons, but this didn't work the way I want, because there's so many positives. What are the negatives, if any? Yeah,
I haven't received that sort of constructive feedback yet. And we did implement an evaluation that we asked patients to kind of do kind of an exit interview. We did that for two reasons. We did want to know why they were moving on from the practice, but my dream would really have like a network of DPC practices where we could all work together. As I said, my patients who are out of state, having someone available who could physically see them in person. So we kind of wanted to know if someone was moving, where they were moving to, that sort of thing. But it is just a couple of folks that I no longer care for, but it was, either someone who needed to have an elective surgery, or someone, a couple of people who felt like they just couldn't afford it anymore due to financial circumstances. So I haven't received the, this isn't what I thought it was going to be kind of thing yet. But no, I think that people really enjoy it. I think it's really the access to the physician and that relationship that they appreciate.
Thank you. Other questions? We've got 2 minutes before we're up on time. While everybody's thinking, if anybody wants to engage in the discussion, please unmute and do that now, or you can put it in the chat. But just as a reminder, look for your course evaluation. That is required to earn your CME credit and certificate. We will report that automatically to AAFP. You're responsible, as always, for reporting your credit to the licensing board for your state credits. Other questions?
Hi, I had a
I-
question.
Oh, sorry.
Sorry, we're wrapping up. I'm Tanika Penn, TM Penn on there. And so I want to start this, and I've been thinking about it. Thank you for your presentation. It was fantastic. I'm just wondering, in your personal experience, what did you find that was the hardest when you were starting out?
I think the thing that was the hardest and the biggest mind shift for me was I really had to talk to folks and educate them on the practice. You know, when you are an employed doc, I mean, I had this experience in Texas and Tennessee, the marketing is essentially done for you, right? Somebody puts your face on a flyer, they're passing it out, they're introducing you in the doctor's lounge, they're sending you email blast about that. And I had to initiate those things. So that was my personal biggest shift or the hardest task for me initially. But once I got the hang of it, and once I figured out, patients really wanted to interact with me and talk to me, and then that's why I did the discovery calls, because I did, you know, just very transparently felt like intimidated by making sure that I was on social media and all of the things that that entails, and what it would look like to put myself out there or even buy ads. But once I figured out that people love conversations, love, like, I would say, if you are a member of any like community organizations or social groups or churches, organizations like that, where you can do a webinar or an in-person conversation, not only about your practice, like give them some value about something else that the community wants to know about, but then also talk about how your practice can help them manage what that thing is. I think that that was the best use of my time and even financial resources in building my practice.
Thank you. Thank you so much.
I see another question in the chat. Do I have staff? So yes, I have one person in person, and then I have a virtual, I have two virtual staff members actually who help manage some back end stuff, but neither of them work full time. And I would say you probably don't need as many people as you think you do when you transition out of the role. And so I would say go slow with that. Someone told me to keep my overhead low in the beginning, and I'm very glad that I listened to that, because it just takes pressure off, and then as you grow, you add. So that would be my help there.
One more chat question here, looks like. You see
Do I
that, Dr.
require
Green?
them or help them? I haven't had this experience yet where there's anyone that I feel like I can't take care of. I do have some older adults that I take care of, but yes, I mean, I would encourage someone and take the time. I find a lot of value in explaining to folks what the ACA programs look like, if they're curious or if it's something they need. I think that there's a lot of misinformation out there. And so I don't have a problem just taking a few minutes to explain that, what that means to them. I don't get on the website and help them vet plans, but I kind of give them some general things that they should probably look at for their situation. And yes, I mean, you know, medications are usually not the expensive part of their partnership with me. I mean, as you all know, Amazon Pharmacy is really popular with my patient panel, because medications come directly to their house, they're low cost. But yes, I mean, if someone is on a medication that is extremely expensive and there's no alternative, then yes, I would encourage them to consider insurance if it's going to be a long-term solution.
Other questions before we wrap up? We've got 7:33. So we're right on time. If you do have follow-up questions you would like to get to Dr. Green, you can send those to us at TNAFP, and we'll be happy to relay them and either get you an answer or put you in touch with Dr. Green if she's available and willing. But if there are none, we will wrap up. Thank you so much, Dr. Green, for this great presentation. We appreciate you